Treatment of complications. Abscess of the urethral glands. Acute relapse or chronic prolongation of gonorrhea because of infection of the glands or of the paraurethral ducts is a matter for treatment in the chronic stages of the disease. Nothing can be done while the whole urethra remains acutely inflamed. Periurethritis. Stop repressive treatment. All pus formations about the urethra, whether diffuse or circumscribed, are treated during the acute inflammatory stage on general surgical principles by rest, protection from friction and injury, moist, weak bichlorid or mild carbolized wet dressing under gutta percha tissue. Incision is required as soon as the abscess is as large as a pea, if not sooner. When the abscess projects internally and not externally, an attempt should be made to open it from within through a urethroscope. When permanent fistula results, it should be treated by Chetwood's method, viz., the injection into the urethral end of the fistula of a 25% ethereal solution of peroxide of hydrogen using a fine-drawn, rubber-capped glass pipette, figure 45, with bent extremity. By means of this instrument, aided by a wire speculum, a few drops of the solution are thrown into the fistula. This is repeated every 3 days until the fistula closes. This treatment should be applied from within the urethra, the internal orifice of the fistula being enlarged for that purpose, if necessary. Fistula that do not yield to this treatment require a plastic operation. If little shot-like bodies remain under the skin, refusing to suppurate actively, these may be excised, but fistula may result. Spongiitis and cavernitis. Core D, the commonest evidence of inflammation in the corpus spongiosum, is a contraindication to repressive treatment. If the erections are rendered more painful by the injections, these must be stopped. Core D is self-limited. It usually ceases in 10 days. To prevent Core D, the patient should eat and drink little in the evening, avoid all sexual associations, sleep under light covers, and arise to urinate in the middle of the night. To palliate it, he should bend the erect penis gently downward and check the erection by immediate urination, or by first plunging the penis into cold water and then urinating. Prostatic massage has been suggested as a means to reduce the sexual tension and so prevent erections. I have not found it of any service, though one occasionally sees an amorous patient in the declining stage of acute gonorrhea benefit by sexual intercourse. The rare true spongiitis or cavernitis is treated by rest and cold or heat until resolution occurs or abscess requires incision. Figure 45, injection of urethral fistula. Balanopostitis, lymphangitis. These are treated in the usual way, pages 645 and 647. Paraurethral canals. Inflamed paraurethral canals or pouches should be slit up as soon as they are recognized, unless the anterior urethra is acutely inflamed at the time. Acute posterior urethritis and cystitis. Under this title, we consider the treatment of cases of posterior urethritis unaccompanied by palpable change in the prostate and too severe to be controlled by routine treatment of the posterior urethra, page 171. In such cases, all local treatment of the urethra must be abandoned. The patient is persuaded to rest as much as possible, in bed if the pain is very severe. Some sedative, such as the liquor potasse and trihyoscyamide mixture, is administered. The bromides are, next to opium, the best sedatives. They may be added to the above mixture. To alleviate pain, I usually advise the constant application of a hot water bag to the perineum and a sitz bath of 5 minutes in water as hot as can be borne, to be taken twice a day, or, if it gives great relief, before each micturition. Some patients prefer to urinate in the bath. Hot rectal douches, very gently administered, not oftener than twice a day, may sometimes be substituted with advantage for a sitz bath, but they may irritate more than they soothe. Sedative suppositories of opium and other drugs are singularly inefficient. Such drugs are more effective and under better control if given by mouth. If incessant pain continues or grows worse under this treatment, and the absence of fever or complete retention, or of a prostate palpably inflamed, shows that there is no marked prostatitis, the inflammation may be directly attacked after local anesthetization of the urethra by installation of 2 or 3 drops of 5 to 10% silver nitrate solution. The installation should be administered with the utmost gentleness in the posterior urethra. The injection may be repeated in greater or less strength every 2 or 3 days. 20% Gomanol or 10% Argyrol are, I believe, not quite so efficacious as the silver salt. The effect of the injection is often a marked diminution in the pain. As soon as this occurs, local treatment is stopped until the symptoms have considerably ameliorated, when it is resumed as in the terminal treatment, page 232. If pain persists in spite of installations, the case is treated as one of acute prostatitis. Acute prostatitis and prostatic abscess. In Chapter 17, we have shown the futility of attempting to distinguish clinically between acute prostatitis and prostatic abscess. The treatment of this condition is prophylactic, palliative, and operative. Prophylactic treatment. The treatment of acute prostatitis, to be truly successful, should begin before there is any abscess, even before there is any prostatitis. It should be preventive. To prevent acute prostatitis, the most important precaution, apart from gentleness in all urethral instrumentation, is a great respect for the urethra during acute gonorrhea. Prostatic abscess is nowadays more often caused by intemperate use of the so-called abortive treatment of gonorrhea, whether injection or irrigation, than by anything else. In only one of my first 5 acute gonorrheal cases had the patient not been taking an, quote, abortive course, while of the 4 whose abscess was directly due to such a course, 3 were married men upon whom Argyrol, 2, or permanganate, 1, had been vigorously employed in the vain hope of curing the disease in a few days. Palliative treatment. The palliative treatment is much the same as that of acute posterior urethritis. If there is acute retention, a small 15 French soft rubber catheter should be introduced 3 or 4 times a day and followed by a mild antiseptic irrigation until retention is relieved. Though if spontaneous urination is not established within a day or so, or if catheterism is difficult or painful because of stricture or inflammation, one should operate at once. To sum up, the palliative treatment consists of stopping all urethral treatment, number 1. Number 2, the administration by mouth of some soothing urinary antiseptic with whatever sedative and laxative may be necessary. Number 3, insistence upon the general rules of anti-gonorrheic treatment, especially as to physical rest in bed if there is fever. 4, hot sitz baths or hot rectal douches with the hot water bag as local sedative. 5, catheterism and bladder wash if there is complete retention. As a result of this treatment, we look for prompt relief of 2 symptoms, viz. Fever and retention. If the patient's temperature does not within a few days fall to and remain below 100 degrees Fahrenheit, and if acute complete retention is not almost immediately relieved, the abscess should be promptly operated upon. Such a rule may seem unnecessarily severe, even brutally surgical, for it takes no account of the precise pathological conditions within the prostate. Yet it is fully as justifiable, fully as necessary, as the rule to operate early in acute appendicitis. In each disease, unexpected cure without operation may follow a long and distressing illness. But such a cure is not to be compared with the immediate relief following upon operation, while the entire safety of such an operation, if promptly and properly performed, contrasts strikingly with the miserable and even fatal results of palliative treatment unwisely prolonged. Operative treatment, see page 730. Seminal vesiculitis and deferentitis. The seminal vesicle very rarely requires treatment during acute urethral gonorrhea. Acute inflammation in it is rare and is habitually but a minor accompaniment to a more important acute prostatitis. The treatment is the palliative treatment of acute prostatitis. When active suppuration occurs in or about the vesicle, this is usually not discovered until adhesion with the bowel has taken place. In this event, the abscess should be incised from the rectum. But if suppuration tends to spread off into the ischiorectal fossa or threatens the peritoneum, vesiculotomy should be performed. Epididymitis, see page 566. Pyelonephritis, see page 350.